Hey Chris, how you doing? Hi Peter, good to have you back. Got a few familiar names on the list there. Hi Natalie, welcome back. Had some really good work off you too, Peter, Natalie. Thank you for that. Some really good research this week. Kept you busy. Hi Nicola, and you as well. Yeah, really good. Some good things. Right, we'll get going, guys, as everyone's coming in. Hi Polly. Okay, so last session of this week, week 2. Hi Emma. Yeah, we're going to finish off Billy's case study, which was all to do with the knee. So there was a few things in there that led towards a possible systemic problem, and so we'll see how you got on with everything. I give you a few clues to go and have a look at some things on Wednesday night. So and thank you for everybody contributing on the Facebook page. I think once you kind of read what somebody else has put, that kind of sparks you off then to go down another avenue. So and it might be areas that you've never even thought of looking before. So hopefully it's helped some of you. So again, apologies if you've heard this before, but my name's Mike. Hey Namir, how you doing? I'm the Education Director of Movement Therapy Education. Just to let you know, we're just in the process now of putting together an education schedule. So we will hopefully launch it sometime next week. So we'll have a few sessions on. It won't just be me. There'll be some of the other guys that we work with, hoping to do some different things, different therapies and stuff as well. So yeah, we've got some really cool tutors that work with us at MTE. So yeah, we're going to introduce you to those guys too. So we'll let you know when all the timings for that is on. I also run movement therapy clinics, and we're linking up with a few clinics again to put together some regular timetables for people, because we had a bit of a meeting this week, and now your area is no longer your immediate vicinity to wherever you normally practice. Your possible reach is worldwide now, so you could have patients all over the world tuning into your sessions. So rather than it, obviously it's affecting us, and we don't get our normal kind of regular face-to-face people, but we're coming up with some new ideas to appeal to even more people. So when those launch next week, I'll let you know about them on our Facebook group as well, and you can have a look and see what you think. And if you like the idea, then obviously just nick our ideas. It's no problem. Yeah, and use it for yourself if you think it will work for you too. So yeah, we don't only teach people, but we also do it ourselves. So and I think that's really important. I mean, for me, I love doing the treatments with patients and working things through, just like we do with these scenarios. So as much as I do teaching, I think the balance of the two is really good. So I'm an osteopath. I was a sports therapist before that, so I came through the sports therapy route. Before that, I was a personal trainer. So years ago, we used to do PT. I qualified back in 1994, so it's a long time ago now. And within the last 10 years, I became a clinical anatomist as well. So I do regular visits to the anatomy labs at Keele and King's College, and we do dissection work and things like that. So yeah, this kind of thing is what I live and breathe for. So hopefully that comes across. Right then, so catch up on this week. We've looked at a case history, so we looked at Billy. We picked out some key points, and then we started to create a clinical sieve to try and sift through all of the information that's there, and then create a justification for the clinical impressions that we had. Okay, so and then what we have to do is put them in a priority list and then work out what the heck we're going to do. So that's what we're going to do today. So this was the plan over the week. So on Monday, we did an intro to the case, and we'll do the same again next week as well. We've got another OSCE coming up next week. Second session, we have a look at objective assessment planning. So that's what we did Wednesday. And then today, the plan, what do we do now with all of the information that we've got? So as always, thoughts and justifications on the Facebook group for discussion after every session. And yeah, there's been some really good ones this week. So thank you for contributing those that did. And I say it as well in the groups that if you don't want to post it online, just send it to me, and we can just have a chat offline. If you're not confident in putting your ideas out there, it's not a problem at all. That's what we're here for. So yeah, and some of you have done that as well, so that's really good. So these are the key points from the sieve. Some of the things that I gave you a couple of hints about as well. So and it's led to some really good clinical impressions this week. So well done, everybody. So we've got a 16-year-old lad. He's quite tall and slight, lanky looking was the description. Constant knee pain for no apparent reason. Occasional paresthesia into both hands. He's had a fall from a horse. He's had a previous road traffic accident with ongoing neck pain. He's had no x-ray after the fall from the horse. He's got head injuries that are he's complaining of, and he's complaining of headaches as well. In his long-term history, that he's had a traumatic birth. It was a von Toos delivery, and then there was a bit of a kind of throwing in a little bit of a hook, really, with his father's bad back history. And Namir, I think you mentioned ankylosing spondylitis. So well done. That was in the case what he had. I'm just going to spell this out for you. Ankylosing. So I'll just pop that in the chat. That's what the father had. And if we haven't got enough time to go into all of the conditions today, so I'll leave that one with you guys to have a look at on your own. If you've never heard of it before, then have a look at that. But then the boy himself, Billy, he was described as having ligament problems by his mum, and his mum couldn't remember the name of the condition that he had. Okay, so we're going to explore that one in a bit more detail. So that was a summary from the case. And some ideas from you guys in the group. So we had EDS, or Ehlers-Danlos syndrome. Had a few of you saying Osgood-Schlatter's disease. And then we had an osteochondritis dissecans. So we're just going to have a look at some of those. So bear with me a second. So this one is EDS. Just make sure that you guys can see that. Yeah, cool. Okay, so this is EDS. If you go to Physiopedia, is a really good resource for this kind of stuff. It's well referenced. So if you click on the editors, it's got all the editors, where they work, what kind of universities they work in, and if you've got any questions about the content, we've got you can cite the articles. That it usually has the references within. Yeah, here you go. So you got click on what, there you go. So there's a whole list of references there. It's not just somebody making stuff up and writing it down on a website. This is actually well referenced. So EDS, if you've not heard of it, is a connective tissue disorder. Okay, and it affects the collagen in the body. So and obviously collagen is absolutely everywhere. So we've got a couple of things that pointed us towards EDS with this lad, and it was his appearance and his kind of gangly nature, and the fact that he kept on tripping and falling. And so that those kind of things are kind of usual signs. He didn't really have that many pointers towards EDS, but there was a couple of things in there that might have made you think down those lines. So that was really good. Then the other one, just go to a different one. was Osgood Schlatters. And if you've not heard of that before, it is to do, so this picture on the right here, you've got the patella there, and then the patella tendon that attaches onto the tibial tuberosity. And this is very common in boys, usually around the kind of age of Billy, about 16 years of age. And what happens is there becomes a separation between the tibial tuberosity and the underlying tibial bone. So what happens is, because the patella tendon pulls on that bone so much, it starts to pull the bone away, and then it gets inlaid with more bone. So more bone is laid down. So you have an enlargement of the tibial tuberosity. Okay, so that could have been a possibility. So that was really good. Well done, those that came up with that one. And then the last one, I think, Sharon, you came up with this one, which was a really good shout. So this was OCD, so osteochondritis dissecans. And if you have a look down here we go. So we've got the different stages of the injury. Now, this usually occurs from direct trauma. So obviously Billy fell off a horse. So this could be one of his differentials, if you like. So we could have just damage to the articular cartilage, or a piece of the cartilage is separating away from the condyle, or there's been a complete separation. Okay, so there are different levels of stages of OCD. Okay, so not obsessive compulsive disorder, but osteochondritis dissecans. So that's again another one that, if you've not heard of it, then worth having a look at. So some really good thoughts in there. Let me just play this again. Okay, so those were the kind of some that jumped out at me from the things that you guys had put on the Facebook group. So well done with that. And then this was our list, and thank you for Peter for sending yours through. So that was really good. I guess what you need to do is work out, am I going to treat the person? And in most of these OSCEs, you're probably not, because they've got some weird and wonderful stuff going on, and you're like, what the heck is that? So most of these, it's probably no, but you need to also say, well, no, but why? And then justifying a reason why. But then also, where are they going to go? So are they going to go straight to A&E? Is it serious enough that you need to call an ambulance for them? I've had one person that I've had to do that for before, where they went to the GP on the Monday, complaining of pain in their arm and kind of going up into their neck. They'd had a fall. I think this is going back some years, and his GP didn't even get him to take his top off to have a look at his shoulder. And we had a look at it, and it just looked completely weird. It didn't look as if there was anything wrong with his collarbone or anything like that, but just the whole look of this lad was really, really strange. So you can use a tuning fork on bony prominences to send a vibration through the bone, and we use it as a bit of a diagnostic for fractures. It's not the best. I mean, they may or may not have a fracture, but you can also use an ultrasound machine as well and turn it up to a really high frequency, and that will also send vibration through the bone as well, and you can possibly detect fractures that way too. Whenever I've done it, whenever I've had to I used it on a scaphoid fracture once as well, and whenever I've had to send people away, they've been confirmed that they've had fractures. So it's something useful in clinic. It's not 100% accurate, but it will give you more information to help you make a decision about what to do. So for this lad, yeah, took his t-shirt off, arm looked all funny. And so I thought that he'd had a problem with his neck, and so I put a tuning fork on the end of his acromion, and I was going to work all the way along the clavicle, just sending vibrations through the bone there to see if anything would go around through to the ribs and then into his neck. And as soon as I put it on his shoulder, he nearly hit the roof. So we sent that lad off to A&E, and we called an ambulance for him. And it turned out it wasn't his neck. That was the referred pain, and that's what he was complaining of. But it actually fractured his humerus. So where I put the tuning fork was just above the area where, but that didn't hurt at all. There was no pain in his shoulder. It was all in his neck. And where I put the tuning fork was just above where he'd had his fracture. So it's no wonder that he hit the roof. But that was one, you know, you think, well, you've been to the GP. He got given painkillers by the GP on the Monday, came to see me on the Wednesday, and we sent him straight off for an X-ray. Okay, so you have to decide: do you go GP or do you go A&E? So it's obviously depends on what you see. So we had thoracic outlet as one of our clinical impressions from Wednesday because of the tingling in the whole hand, and we talked about that last week about doing Adson's test and the possibility of a cervical rib, so maybe needing an X-ray there as well. A possible central cord compression because it wasn't just one hand; it was both hands. So there may have been something wrong with the spinal cord itself, but it was only a loss in sensation, we say, but there was no power loss or anything like that. So, but it still could have been a cord compression. So for me, that would be an A&E job. Okay, he's had a fall from a horse, and then he's got tingling in both hands. So that's A&E anyway. And then we've got skull or cervical fracture. And again, because he's fallen from a horse, he's got neck pain and head pain. So that's straight to A&E. That's a first aid incident, that one. Okay. Raised intracranial pressure. So he might have a bleed on the brain. That might be why he's been getting his headaches. So again, that's another A&E job. Okay, so there's quite a few there. If he had none of that, if he hadn't fallen from a horse and he was just coming in with achy neck and shoulders because he'd been playing sports or whatever, then you would go through your usual neck and thoracic exams. Okay, we're going to go into this one in a little bit more detail in the next couple of slides. So osteosarcoma. Because of his age, we'll talk about that in a bit. It's the constant pain, the night pain, and the location of the pain. He may have bone cancer. Okay, so that is something that we're going to life-threatening. Okay, so it's probably not an A&E job, but it's definitely you need to go to your GP as soon as you can. Patella fracture potentially, again because of the location. It didn't say exactly where on the knee that it was sore, so we could put that in there as well. And then a connective tissue disorder because of the lanky appearance, so a possible Marfan syndrome or Ehlers-Danlos syndrome. So they're both connective tissue disorders, and there was a history of potential spinal issues with his dad as well. Okay, so there was some hereditary factors that were thrown in the mix too. We're going to have a look at this in a sec. So something called the Baton score, but that might be something that you would refer to the GP, and they would then go to a specialist physio. I've seen quite a few patients with Ehlers-Danlos syndrome. We've got a lady doing our diploma at the moment that works on the South Coast. She's an expert in it. She's writing a book about EDS. Yeah, when it's published, we'll let you know. But her name's Bonnie Southgate, so she's worth checking out. Or if you're around the Bournemouth area, if you think somebody has got hypermobility syndrome or EDS. Okay, so yeah, definitely somebody to worth checking out. Then we've got obviously soft injury from the fall from the horse, so it could just be soft tissue problem, or it could be a cervical facet irritation, so the neck ache, previous road traffic accident, and I'll put neck aching in there twice, and we just do a cervical. And then this is the one that I want to focus on. So osteosarcoma is basically a bone cancer. Okay, so he fits the profile, usually under 30 years of age. The peak of developing 2% of primary bone tumors, so it's quite common. Are we back? Sorry about that. Okay. Yeah, so it's usually found in the distal femur or the proximal tibia. So it's in the area where our person has had their symptoms. Okay. So what a couple of the key things why we think it might be this and this forefront, because it happened for no apparent reason. So we didn't cool, thanks guys. Didn't have any problems beforehand. So we had this before he had the, so that's why it's really worth having a look at the previous history, yeah, and finding out exactly when they fall, okay, because we can assume things. We can assume that oh yeah, the reason why he's got knee pain just because he fell from a horse, but we know that this started at least 3 months before. There was a little bit of a red herring because he had a car accident as well, but I guess if he was your patient, you'd need to investigate that a little bit more. And did he have a problem with his knee after the car accident? Okay, so maybe or maybe not, but it's something that with night pain, constant pain, no apparent reason why it started, those are all red flags, and that is one of the reasons why he may have had those symptoms. Okay, so that's a biggie. These are some of the things. Let me just move me a sec. So that you've got a couple of things that you can use in clinic for people that have hypermobility conditions or connective tissue disorders. Specific tests. With Ehlers-Danlos, it's a collagen problem. And with Marfan's, it's a fibrillin problem. So we've got there are different types of connective tissue, and Marfan's affects a different connective tissue cell than EDS does. Okay, so we wouldn't be able to tell that. We would just know that it looks a bit strange. Okay, so you've got something called a Baton score, and if you want to have a look at that, I'll just pop that in the box here. So your Baton score is a series of tests that you can do. So you can see those on the right hand side, and you give the person a score. So something really quick and simple you can do in clinic. And if they score, I think it's 9 points. Yeah. So if they're scoring 9 points on there, then they're quite likely to have some kind of connective tissue disorder. So it's worth then sending them to their GP to get assessed by a specialist. Okay, and then with Marfan's, one of the tests that you can do is your hand span, or your arm span, bigger than your height. Okay, so if you've got really long arms and really long fingers, those are some of the signs of Marfan's. Okay, let me just show you this. Okay, so these are some of the things that you can have a look at for Marfan. So we've got the handshake, we've got being able to tuck your thumb all the way through underneath your little finger. Okay, so that's a sign. And can you get your fingers all the way around your wrist? So if you've got really small wrists, yeah. So again, you get points for all of these things. Have you got quite stretchy skin? Okay, so we've got hand skin quality there as well. All right, and then it gives you the scores. So you can use these things in clinic with your patients. Do that with ballet dancers. Yeah, perfect. Yeah, I often find, Sharon, that with ballet dancers, and the reason why they do ballet and they do gymnastics is because of their amazing flexibility. Okay, so because of the makeup of their body, they naturally gravitate towards those kind of sports because they're bendy. Okay, so quite often you will find that. Yeah, what some of the things you've got to be careful about. My patient with EDS, because it affects your blood vessels as well and your digestion. It affects everything because everything's made of collagen. So she gets POTS, which is where she faints. So and it's because the blood vessels, they can't maintain blood pressure because they're so loose. It can't push the blood around. So the blood vessels will dilate because they lack that rigidity from the collagen changes, and then the blood pressure drops, and then they faint. Okay, so you can end up with injuries from the fainting. You can also have problems with the valves around the heart. You can have problems with the thoracic aortic aneurysm. So where the aorta comes out of your heart, it can start to balloon, and because the connective tissue around the aorta isn't strong enough to be able to withstand the force of the blood being pushed from the heart, so it starts to expand, and it ends up like an aneurysm. So you can have problems with that as well. I mean, I remember when my tutor at university told me that. Let me just show you a picture. He said, just show you this, that people with EDS have blood vessels like windsocks. Okay, so they've just got no rigidity. They can't push the blood around. It's like floppy blood circulation. Okay, so it's you can have problems with all sorts of areas of the body, and in particular in the neck. Okay, so if you suspected this guy had EDS, just turn that back on again, and then and he's had a fall from a horse, that could potentially be life-threatening, because the ligaments in the neck, if with EDS, can be really lax, and then the head is then unstable, and that can kill you. So you can have something called a Chiari malformation, and that's where your brainstem will start to come through the foramen magnum, which is the base of your skull. It's quite it's a really nasty disorder. It can really change people's lives. It depends on how bad they've got it, but it can be really life changing. A couple of conditions if you've not heard of them before, and those are some things that you can do in clinic with them. Alex, good. So exactly what I find with all my dancers, they fall into it young due to the amount of movement that they have through the hypermobility. Sometimes though people just assume they're really lucky because they're so flexible, but then don't really give them any more info or help them with other aspects of the condition. Yeah, they've often got massive amount of range, but then they're not able to control it, and that's a real problem. Okay, that they will just keep going, but they won't stop. We did some interesting strength tests with someone with EDS, and they really lacked strength. They had really good muscular endurance, but really poor strength. So it's quite interesting. Cool, really good discussions there. Cool, and that's it for this week. So quick half hour. So young Billy, yeah, me too. I'd have sent him off. And you're probably not going to be able to touch the next one either, but you need to work out why. So Billy probably had EDS, and because he doesn't exist, so we've no idea, and he probably had an osteosarcoma. He's a really unlucky kid. We're going to see who's unlucky next week on Monday. So next week, Monday, 6 o'clock, we'll have a new OSCE for you. Keep your brains ticking over. Keep contributing in the group, and we'll let you know of the other things that we're going to be putting on as well. And we'll put a schedule together. Thanks for everybody who contributed throughout the week and tonight, and have a good weekend. See you guys.